afternoon, everyone. Hi, Vicky, for introducing me for that kind presentation. I will share my screen to start my presentation. Okay. Before starting, I want to say that I'm from Argentina. My mother tongue is Spanish. So my apologies in advance with any mistake with English. I'll do my best, I promise. And well, in the next few minutes, I'm going to present you one of our most recent innovations in hearts in the Americas, the hypertension clinical pathway, and its importance of hypertension control in the primary care setting. As you know, the scientific knowledge has evolved from that based on pathophysiological reasoning, from that based on clinical evidence. That means evidence-based medicine. But having evidence is good. But the problems begin when you put hypertension in a medline and the database bring us almost 600,000 articles, and this is a real scientific pollution, and nobody has the time to keep updated. So from that point, having clinical guidelines are good and seems to be a solution for that scientific pollution, but they are also take part in the problem, because most of these clinical practice guidelines are extensive, are complex, bring us different ways to ways of to address the patient problems and introduce complex strategies that um, make the clinical practice um, uh, mm, that make the clinical practice more complex. And last year, in September 2021, World Health Organization released its last hypertension guideline, and this guideline is focused on implementation, establishes different thresholds for the initiation of pharmacological treatment for hypertension, establishes a different target, blood pressure targets, introducing a strong perspective of cardiovascular disease risk assessment. This guideline also establish specific medication classes and encourage the use of fixed dose combinations, and also introduce the relevance of having uh, properly trained non-physician health worker that those can treat the patients using standardized treatment protocols. And also in the Hearts in the Americas, um, Hearts in the Americas has joined a different specialist from many Americas country, from different um, um, profile into the health team, the healthcare team, from the United States, Argentina, Chile, Ecuador, and many other countries. And as I said, many different profiles, such as nurses, doctors, epidemiologists, cardiologists, nephrologists, general practitioners, and others. And this group, called Heart in the Americas Innovation Group, published recently, 2 months ago, in the Lancet Regional Health Americas, this paper. And this paper, called Drivers and Scorecards to Improve Hypertension Control in Primary Care Practice, is a very strong tool to catalyze the latest recommendation for hypertension and CVD management at primary healthcare. These 8 drivers and their 17 recommendations, um, related to blood pressure measurement accuracy, CVD risk assessment, standardized treatment protocol, treatment intensification, continuity of care and follow-up, team-based care and task shifting and task sharing, and medication refill frequency or system for performance and evaluation with feedback, are in the center of the HEARTS implementation, and they are key to reach higher rates of hypertension diagnosis and control. And in Heart in the Americas, we um, put it all together and developed the Heart clinical pathway. HEARTS clinical pathway represents the ABC to CVD management risk at primary health care. This one page um, brings us all tools to improve the healthcare of our patients. And in the step A, recommends measure blood pressure in all adults and adult visits. That means a broad screening strategy and using a standardized protocol to measure blood pressure. And obviously, we are recommending the use of validated automatic devices for the arm, whenever available, obviously. And then in the step B, we introduce the cardiovascular risk perspective approach and encourage um, all um, patients to measure, to estimate the cardiovascular risk using another HEARTS development, such as the HEARTS app. This app includes the latest um, CVD risk chart from the WHO. And finally, in the step C, we have the treatment protocol, and this treatment protocol recommends start treatment immediately after confirming hypertension. That means no delay the treatment initiation more than 4 weeks. And also this step recommends initiate initiate the pharmacological treatment for hypertension when blood pressure is over 140/90, and if systolic blood pressure is over 130 in high risk hypertensive. And the classification based on cardiovascular risk is quite pragmatic, and considering only four situations, we can classify patients in different CVD risk categories. For example, if uh, our patient has a history of established cardiovascular disease, this patient is at high risk. Or if not, but our patient has diabetes, this patient is at high risk. And the same with chronic kidney disease, uh, or if all these three conditions um, are not present, uh, so in that case, we encourage to use the calculator to estimate the cardiovascular risk, and we are considering high risk um, patients with a threshold of 10% at 10 years. Um, in this chart, we include the different targets for hypertension control, that is below 140/90 for all hypertensive patients, but below 130 uh, of systolic blood pressure for those hypertensive patients at high risk. Um, Depending on the present the presence of established cardiovascular disease, we recommend the use of aspirin in secondary prevention in patients with history of myocardial infarction or stroke. And in those patients, we are recommending also um, high dose studies. And for the rest of high risk hypertensive patients, but in primary preventions, we are recommending moderate dose studies, and we are not recommending the use of aspirin. And finally, in the center of the clinical pathway, in the heart of this clinical pathway, we can find the standardized treatment for hypertension control. And this protocol, this algorithm is a straightforward, linear, has a straightforward linear structure, and recommends the initiation of combined therapy using two antihypertensive drugs, preferably in fixed dose combinations at a half maximum dose, and also establish a monthly follow-up until the patient reach hypertension control. and in each visit, the treatment is intensified from half maximum doses of two medications to high maximum high doses or maximum doses of the same drugs. And if the patient is not controlled at month, so we are recommending to add another a third drug. In that case, in this example, uh, this is a chlorthalidone or another diuretic, and if the patient is not controlled at month, so we reach a situation of three antihypertensive drugs at maximum doses. Um, we also include in this protocol the most important recommendations related to healthy lifestyles, such as avoid foods high in sodium, or healthy nutrition, or physical activity, or a recommendation against smoking. Um, as I said, uh, we um, we are just recommending uh, four step for medication titration and repeat measurement um, um, in all patients that first reading are um, elevated, and establishing a monthly interval of follow-up between visits. And the bottom of this algorithm to treat hypertension, we also include other recommendations related to follow-up in patients under control, and this follow-up is set each is set um, at a minimum of 6 months in all hypertensive, that means in low and moderate risk hypertensive patients, but a minimum follow-up of 3 months in high risk hypertensive. We include we have included another driver, another key driver in this clinical pathway, such as the supply medicines for 3 months to increase the adherence and the persistence in the treatment. And we also include a vaccination recommendation related not only with COVID, but also related to influenza and pneumococcus. Um, Other recommendations are also included in this clinical pathway. For example, take all medication at the same time every day. That this recommendation is quite important to improve treatment adherence. So the hypertension clinical pathway is the main tool for HEARTS implementation, catalyzing the recommendation from the new WHO guideline and the HEARTS drivers for hypertension control. And to conclude, I can say that there is a real pollution of scientific information on hypertension, and this also includes the clinical practice guidelines. The traditional model of care based on clinical practice guidelines has failed to achieve high rates of hypertension control. The right answer is the implementation of a simplified and standardized approach such as HEARTS in the Americas. The HEARTS clinical pathway is the core of HEARTS implementation, enabling a more comprehensive approach to CVD risk management in primary healthcare. So, thank you for joining us, and over to you, Vicky.